Welcome. Hi, and welcome to this episode of Perimenopause What the F podcast. So, we're going to get some questions answered about millennials and perimenopause today. Some may call it millennials. So, I'm very privileged to have the opportunity to speak with Dr. Jayne Morgan today. Dr. Morgan, can you please tell us a little bit about yourself?
I certainly can, Kristen, and I really love being here today. My name is Dr. Jayne Morgan. I am a cardiologist in Atlanta, Georgia. I also have a really extensive research background in both the industry and at large study sites and medical centers. So that's probably my background in a nutshell. Very interested and invested in clinical trials, women's health, and the overall equity question with regard to access to healthcare and how we are communicating the information surrounding science.
That is amazing. You are amazing. So, thank you for all that you do, first of all.
Thank,
So, thank you
thank
for
you.
sharing.
Sure.
So my name is Kristen. Very nice to meet you again. And I'm also known as Queen Ayoke on social media.
Mhm.
I'm a wife and a mom of three. And I'm an entrepreneur. I'm a content creator. I really enjoy just doing what I can to fulfill my passion, to make people laugh, and to just spend time with my family. And as I was creating, or I guess content creating some of my videos, you might see that some of them reflect some of the things that I deal with. And some of those things are symptoms that may fall into the perimenopause status. So, to be honest, I'm a millennial and perimenopause never crossed my mind. So, a few years ago, I actually had a few um, physical changes that, alerted me, rang a little bell. I talked to my mom, I talked to my friends. And as I did research, I was surprised to find that it actually starts for women mid to late 30s, early
Mhm.
40s.
That's true.
And I
Good
was shocked.
research. Good research.
I was, I was shocked. So I'm sure that there are some women that are, here now listening in and they have some questions because I've just, I feel like I'm not prepared.
Mhm.
So we definitely have a few questions from the Perry community. I've got them listed here, and I do have a few questions myself.
Sure.
Uh, but to get started, can you define perimenopause for us?
So perimenopause are those years prior to menopause, and menopause is defined as 1 year after your last menstrual period. But that
Mhm.
decade or so leading up to that is actually that perimenopause period of time where, and it can be more than a decade, it can be up to 15 years ahead of that. That's called
Oh,
perimenopause, where you're leading up to when you'll have your last menstrual cycle, and during that time, your estrogen levels are slowly beginning to decrease over time. And this is somewhat of a confusing terminology for people because oftentimes during perimenopause, you don't know that you're in menopause because we never really talk about it. And you're still having regular menstrual cycles. Everything is normal. You're still fertile. You can get pregnant. And
mhm.
so how could we be in perimenopause? What does that mean? Because most people associate that with not having a menstrual period, but it actually turns out that entire period leading up to menopause is called perimenopause. And we want to be careful and make certain that we identify exactly what that time period is
Mhm.
in our lives, because we can start to have any myriad of new symptoms, confusing symptoms, and you may not
Right.
relate them at all to menopause because our parents really never have a conversation with us. That's because nobody had ever had a
Yeah,
conversation with them, but that's because the doctors don't have a conversation with you about it because people don't
exactly.
really uh, have a way to treat it, so to speak, and we can talk about that.
Right.
And that's because that's how we've been trained as physicians. It was not a part of our training. If you've come out of medical school or training at all in the last 30 years, it was not a part of your training. And so women have just sort of dealt with it silently. But one of the reasons that I've sort of raised my voice and come to the forefront as a cardiologist is because increasingly menopause is very evident to me as being a cardiovascular risk factor. In other words, a risk factor for heart disease. And so that means the perimenopause years are incredibly important, such that we can begin to identify that, because the lower your estrogen levels are, the higher your risk of heart disease. And during this entire period of time, and some women are lucky enough to be asymptomatic, meaning they don't have any symptoms. I have never met one, but I read that they exist. I personally have never met anyone who's had no symptoms.
Right.
According to data, they're out there somewhere.
It's possible?
That's
Oh
so
my
I've heard.
goodness.
I have no personal experience with knowing a single person who hasn't had symptoms. And I wonder sometimes with the women who say they're asymptomatic, if they've had symptoms and they didn't identify or recognize them as symptoms of perimenopause, because there can be some unusual symptoms like a change in taste or itchy ears. And we can talk about that, where who would think an itchy ear or a change in taste or difficulty moving and rotating your shoulder are all related to menopause. So I always wonder if these women really are asymptomatic, or if we just haven't sat down to do a really controlled scientific study and make certain someone is interviewing people and documenting what symptoms are.
Wow. You you just blew my mind. I'm not sure like just everything that you said, the
Mm-hmm.
symptoms, the symptoms that you wouldn't relate to
That's right.
perimenopause. How do we it's like, how do we determine? I know, of course, we need
Right.
to talk to our doctor, but
Mm-hmm.
how do you determine and separate the two? And then how do you say, okay, well, let me treat this as perimenopause or let me treat this
Right.
as something else? So I guess in that regard, we can go to the first question.
Okay.
What are the first signs of perimenopause?
Right.
And I'm taking notes, so you
Right.
might see me over here trying.
And so the first signs can be no signs, right?
Right.
And it all varies. So I'm going to give you a broad spectrum, but feel free to chime in and tell us what your symptoms are. So again, kind of this weird change in taste. You may start to realize that your favorite underarm antiperspirant deodorant doesn't seem to work as well anymore. Have you gone to the bathroom recently? Do you have a drawer sort of full of deodorants that you've kind of been cycling through the last 2 or 3 years, and you keep searching for a new one, a new one? Now you've
Oh,
got a whole
wow.
drawer of stuff that doesn't really work.
Yeah.
It's a sign of perimenopause. If you are, in the corporate world, are you taking an extra blouse or an extra top to work sometimes because you feel like you're not fresh anymore in the middle of the day? You've got to sneak into the bathroom and kind of wash up and change your blouse, and your blouse
Mhm.
actually does smell. It's going to the dry cleaner. So these are all things where we are, very symptoms that you're not thinking about, like, oh, what's wrong with me? Or why does my deodorant
Right.
not work anymore? Oh, my body's
Right.
changing. Itching ears. The reason that
Itching
your
ears.
ears itch is because as your estrogen levels decrease, it can cause a dryness of the skin. That includes the skin inside your ears. So that dry skin can itch your ears. And
Oh
so
my
you may
goodness.
not think about it. You are wringing your ears and talk, but you're not really thinking, hey, this is a new symptom. This is, what does this mean? You're just thinking, what? I've got allergies. I need to take my
Right.
Zydeco. What's wrong with my ear? That
Yes.
sort of thing. Or you scratch it and kind of move on and you're not thinking about it. And at some point you go, why do my ears itch every morning? But it's sort of a rhetorical question because nobody has an answer for it. You sort of just say that to yourself, but
Mhm.
nobody ever connects the dots for you. Right. And so you just continue down this road of perimenopause. And again, because nobody ever discusses it, you're having regular menstrual cycles, regular periods, you're right on schedule. Menopause is when you're not having periods. So there's nothing wrong
Right.
with me. It must be my allergies, or maybe I burned my tongue and my taste
Right.
buds aren't working, or Maybe they've changed the formulation of these deodorants. I don't know why they don't work anymore. I'm up to deodorant number 10. Now I'm having to order them online, that kind of thing. Those are all symptoms of perimenopause that we don't really talk about, including like a little bit of heart flutter, which can be a little bit, can be a lot, palpitations in your chest,
Oh my
um,
goodness.
which can be alarming. So these other symptoms that I mentioned maybe are not alarming, won't send you to the doctor, but palpitations might.
Right.
And then you go to the
Absolutely.
doctor, and, you may get a big workup, and that workup is negative, and you're kind of, maybe sent home on a medication called a beta blocker or a calcium channel blocker, meaning these are just medications in some ways that kind of slow the heart a little bit to control palpitations. When in fact, what's really happening is that your estrogen levels are dropping, and you probably need to see a menopause specialist and have some estrogen added to your therapy. So these are all kind of, symptoms that
Ah,
are wrapped up. And again, you know what? Our parents had the conversation with us about sex, the birds, the bees. Nobody ever discusses menopause. And I began to take an interest in it when I began to connect the dots with regard to some of the more serious symptoms. I listed
mhm.
some of the symptoms that can kind of start in perimenopause that are less talked about. And so
Right.
you just to have your antennas up to say, oh, I should think about some of these unusual ones. But some of the
Yeah.
ones that we know about are these hot flushes, which used to be called hot flashes. Now they're
Hot
called hot
flashes.
flushes. So
Oh, they're
same
called hot
thing.
flushes now.
They're
Okay.
called hot flushes now. And listen, the nomenclature changes. Nobody asked me for my opinion. So I'm going to just tell you why I was told when I questioned it as well, right? I was not asked to weigh in on this at all. So it was just handed to me. So the nomenclature is changing because it was decided, I don't know by whom, I don't know who these
Mhm.
people are, it was decided that hot flashes sort of denote something that happens quickly in a moment and passes. But that's not what
Mhm.
happens when a woman's body is heating up and she's beginning to perspire. It's really a hot flush. It can last for several minutes to 30 or 40 minutes. And so they've decided this
Mm.
is not a flash. That is a misnomer. This is a flush that lasts
Okay.
for a period of time where you're ripping off your clothing and you're drenching wet. So that's supposedly, this is what I've heard. This is like the gossip in the menopause world. I don't really know. I wasn't asked, but that's why the nomenclature is changing. So if you see hot flushes, it's not a new symptom like, oh, what's that? It
Right.
flushes are hot flashes. Just
The same
if you
thing.
see either nomenclature, that is fine. So,
Okay. I'm glad you clear look, I'm glad you asked. You said,
right,
"I'm going to ask about this." I see why the wording is different.
right,
Either way, I know it's the same thing, but I have experienced that. It was a
right.
very short
And
period.
that's right.
Oh
And
my goodness.
irregular periods as well can begin to start the closer you get towards menopause
Mm,
in perimenopause. And again, if you're having irregular bleeding of any type, you should absolutely see your gynecologist and get it checked out. Don't just automatically chalk it up to perimenopause, but it is
yeah.
the period of time when you can start to have irregular cycles, especially as you get closer to menopause. But again, check in with your gynecologist and make certain any degree of abnormal bleeding or spotting isn't due to something else, especially if you've never had the HPV vaccine, the human papilloma vaccine, which is the
Mhm.
only vaccine that we have that protects you from cervical cancer. If you have never had that vaccine, then want to make certain that any irregular bleeding that you don't just write off as perimenopause. You make certain that
Wow.
you see someone first, get a pap smear, make certain that you're fine. Um, but irregular bleeding is also a hallmark of perimenopause, especially the closer you get to menopause.
So, with everything that you've explained, just it's a lot of information, but wonderful information. How would blood work be checked for this? Like, is there a
And
certain time that your cycle could be checked along with the blood work so that that would show?
Most physicians won't check blood work because it can be very variable, but I would
Mm,
talk with your physician about what that is. Perimenopause really is a diagnosis of symptoms,
mhm,
including, again, I haven't talked about some of the more serious symptoms, including like memory fog, brain fogs, word searching, looking for
mhm.
words. You can't seem to figure out why you walked into the room, and you got to go back out. And then 10 minutes later, you're like, oh, I got it. Let me go back in there. Kind of
That's
this,
me.
this you know, uh, being lost just a little bit. And for some women, sometimes it's just that simple. You kind of forget why you walked in the room, or you're having some difficulty. You're searching for words. You know the words on tip of your tongue. You can't come up with it. But for others, they actually have had to step away from their careers because they
Mhm,
cannot maintain their memory for that period
no.
of time. And it's very frustrating, and it can have a significant financial impact. You have to change careers. So again, all of these things have kind of been ha 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 in the past, but we've got to begin to think about them more carefully, more intentionally, and make certain that we are absolutely taking care of ourselves, including our mental health. Speaking of which, menopause is a period of time when the prescriptions of antidepressants for women also doubles. So your
Mm,
doctors, again, are not recognizing these symptoms because what? You can have mood swings. You can be angry. I do something called the Stairwell Chronicles, where I sit on my stairs. If you follow me on social media, it's
mhm.
Dr. Jayne Morgan, DrJayne Morgan. If you follow me on social media, every Wednesday, I sit on my stairs, and for 60 seconds, I answer a question about health, anything, right?
Right.
Anything. So I talk about hypertension, talk about heart disease, I talk about menopause, talk about COVID, I talk about vaccines, I talk about clinical trials, whatever. Answer a question. I do a lot on women's health. I do a lot on health equity, but I do other topics. So I preface that to say that in the last maybe 2 or 3 Wednesdays, I can't remember when. So every Wednesday, Wellness Wednesday, I post something. I did
Okay.
post something about unusual symptoms of menopause. And tongue in cheek, I did say in that, are you angry with everybody? So
Oh, goodness, okay.
in other words, you've got these mood changes, you're not feeling great, you're irritable. It's sort of not, oh, mom's not a nice person, or it's part of the whole symptom. So if you're also feeling more edgy and I wouldn't even call it unhappy. I would call it, easily irritated,
Mm,
annoyed, not unhappy with yourself, unhappy with other people,
right.
right?
That is a
You're fine.
concern.
So I talk
That
about that in 60 seconds or more in one of my Stairwell Chronicles. So that was maybe a couple of Wednesdays ago. If you want to check it out,
yes,
only 60
absolutely.
seconds. Listen to what I have to say about it, and feel free to follow along.
Absolutely. I will definitely check that out. The information you're giving, you've just been so helpful and supportive in just giving all the details, and especially going back to parents, not really having that talk. And not to say, like, I had a good talk with my mom about it, but I guess it's not something that it just doesn't come up naturally for some odd reason. I don't know why it's just not brought up until it happens. So I'm glad that we're having a talk now, and this is something that I can teach my daughter, talk to
Right.
my daughter about ahead of time. Um, so looking back at what you said about periods and irregular periods, I have a question here, another question. Can we still have normal menstrual cycles and be in perimenopause? And I apologize, excuse me a minute. I'm just gonna adjust my plug as you answer that
Yeah,
question.
no problem. Absolutely. And that's why it's confusing, but you absolutely, it's why it's perimenopause. It's this this period of time leading up to it. But the closer you get to menopause, the more irregular your cycles will become. But yes, you can be having completely normal, regular menstrual cycles like clockwork.
Mm.
And you can still get pregnant. I want to be clear. Don't throw out your birth control if you're not,
Yeah.
if you don't want to have any more children. You can still get pregnant during this period of time as well. So, just something to consider. And Kristen, you make a good point about not having the talk. And honestly, I don't blame our parents. I don't blame anyone. Nobody
Mm.
talks about it. Your
Right.
doctor doesn't
Yeah.
talk about it.
No.
Nobody's trained on what are we going to say? There's nothing to say about it. But
Right.
here's something that is really a good piece of information that I actually learned recently. There is a doctor named Dr. Mosconi who wrote a book about brain health after menopause. And as it
Mhm.
turns out, in her book, when they looked at women after menopause were happier than prior to menopause. The joy factor was greater. So it seems to be after you can actually transition through these symptoms, you are calmer. You seem to be happier. You have a better sense of self. Now, whether that has to do with menopause or whether that has to do with age and wisdom and grace, but it's kind of interesting. So you have something to look forward to that once you get through this period of time, there seems
Mhm.
to be a sense of calm and a sense of joy and a better sense of self-perception. So, again, that might be age and confidence and knowing who you are. But it's an interesting analogy that was drawn by Dr. Mosconi.
That's fascinating because
Mhm.
with all of the symptoms and the things that we go through as women in general, just hormonally, emotionally, um, physically, of course, you would think that after that transitional period, it would be more difficult for us, but it's like a sense of peace, like you're saying, just a calm
There
and
seems to be a
wow,
calmer. Yeah,
calm.
better. Everything is the on the end.
The signify the
The ers happen after. Yeah.
Wow. I guess I don't know if everyone agrees with me on this, but I feel like as I've gotten older, I've definitely um felt more confident in who I am, and that really didn't happen until my mid 30s.
Mhm.
I felt a little bit embarrassed to say that at first, but after getting married and starting a family, it's like you really don't have time to be yourself. It's
That's
like
right.
you're an autopilot. Of course,
Right.
they're my hearts. My family is my heart, but
Right.
you're an autopilot. You're constantly doing something for them or someone
That's
else.
right.
And then as they get older and you start to transition into this period, you're actually blossoming and finding out who you are as a person. And I think that's absolutely amazing. Like is in a way you can kind of look forward to it. So I'm
Mhm.
really glad that you pointed that out about you said Dr. Mosconi.
Mosconi,
Um Mosconi.
Mosconi. And you know what else is interesting? You bring up a good point. There is maybe a sense of satisfaction or freedom, maybe, because for many women, by the time they've gone through menopause, they've raised their children. And children are out of the house, or at least have one foot out of the house. And that still, in this day and age, the raising of children is still predominantly on the woman. The woman spends the most time in child care and child rearing, and that is independent of their career, no matter how demanding or non-demanding. And that although joy, that is also stress and responsibility. And when that responsibility uh, is gone, then there's also an opportunity to focus more on ourselves than we have been, and that may also be contributing to sort of a sense of calmness, um not having not having so many people depending on you constantly, not having to meet the demands of the family, Um,
Mhm. I
Definitely
agree.
to a greater degree than your husband does for sure. And I've been married twice, so I know it. Both of them are
Oh,
the same, right?
yeah. You said, "Wait,
Same
let me
as
just let you
keep
know."
the first one, right? They're all this is gonna be the same.
Right. It's really good to hear that. So yeah, I agree with you. I do agree.
Right.
Uh, and we do have another question from one of our Perry community members. How should women who have entered perimenopause through cancer treatment think
Mhm.
about heart health?
So when we talk about the heart, we haven't talked about the heart. Good question. I'm a cardiologist. Let's talk about that. When we talk about the heart, let's talk about menopause, no matter how you get there. So you got there through cancer treatment. Someone else gets there, through another method. Maybe they just reached menopause naturally. Someone
Mm.
else maybe has had a hysterectomy, had the ovaries removed. So however you got there, you're now here. Risk factors begin immediately with menopause. They actually start during perimenopause because what happens during menopause is that your estrogen levels have dropped.
Mhm.
Perimenopause, which means the time preceding menopause, those estrogen levels are slowly decreasing, but they're at their nadir, at their lowest when you reach menopause. Estrogen has a protective factor for the heart. It not
Oh
only
my goodness.
protects against heart disease, it protects against inflammation. It is also important for the development of something called hyaluronic acid, which is also in your joints. But I'm going to stick with the heart for a minute.
Okay.
So, a woman's risk of heart disease is half that of a man's prior to menopause, 50%. And this is one of the reasons why, for the most part in our society, we don't think of heart disease as a woman's disease. It's a man's disease. But the fact of the matter is, the number one killer of women in the United States, decade after decade after decade, is heart disease.
Heart disease. Wow.
Secretly,
Wow.
although we focus on breast cancer, heart disease is what kills us. And even at the height of COVID, our worst variant, Delta variant, with all of our deaths, we had a total of 1.2 million deaths in this country. It
Mm.
never knocked heart disease off its throne as the number one killer.
It did.
That is
So
how
heart disease
serious
still topped.
stayed number one
Oh
through
my
every
goodness.
single variant. So I want to say that because we're going to have this talk about heart disease. It was such an excellent question. Glad you asked that. All right. So by the time so remember, I just said your risk of heart disease is half that of a man's prior to menopause. By the time you reach menopause, remember that's 1 year after your last menstrual period.
Mhm.
Because of those dropping estrogen levels, your heart disease risk is now equal that of a man's.
Oh my goodness.
Then by the time you reach 70, it is greater than that of a man. Now, here's something else. Your symptoms of heart disease, just like some of these more lesser known symptoms of menopause and perimenopause, your symptoms of heart disease or heart attack may also be different from that of a man's. It may not be this crushing chest pain, this shortness of breath, this sweatiness, you lose consciousness and collapse, somebody calls 911, all this drama. No, it may be, which is fine. Those are all symptoms of heart disease. But it could
Mhm.
be you just have a nagging pain in your jaw that might actually send you to the dentist to look at a tooth. You could have back pain. You could have shoulder pain. You
Oh my
could
goodness.
have chronic fatigue. Who's not tired raising kids, dealing with the house, dealing with the job? You could have flu-like symptoms that you just can't seem to shake. Those can all be symptoms of a heart attack in a woman,
Oh my
not
goodness.
only would be overlooked, but would also cause delay in therapy on two different sides. The woman might delay seeking therapy, seeking medical attention for those types of non-specific symptoms. We'll call them non-specific because I don't have a better term, but I'll tell you what they're called right now, which I hate. They're called atypical symptoms. And
Atypical symptoms.
I hate what the word atypical denotes, because even when we say that, it wires our brain to think this is not normal, something, a deviation away from the standard, something unexpected, something additional to learn, rare. But the fact of the matter is, we are 51 or 52% of the population women, which is the majority of the population. So how could we be having the atypical symptoms? We're the majority of the population. So this goes to show you how gender bias also drives medicine. So the fact of the matter is, it may be the men who are having the atypical symptoms, this crushing chest pain, shortness of breath, that actually may be atypical. And the women, who are the majority of the population, may be having the more normal symptoms, but it's not learned that way because medicine is still by and large led by men. It's been created by men. It's been developed by men. Our clinical trials are by men. So I'm going to get off my soapbox with that for a minute. So I'm going to get away from using the term atypical, but that's what it's called. I'm going to say nonspecific symptoms. So these are symptoms that not only you may not recognize, but guess what? When you see a physician, they may not recognize it either. Oh,
Wow.
doctor, I just feel tired all the time. I feel like my back is hurting. I'm tired, et cetera, et cetera. Does that send you for a cardiac workup? No, but it should. If you're over the age of 35 and you're presenting with those symptoms, because your risk of heart disease is increasing and your estrogen levels are decreasing. And so by the time you get around to maybe having a cardiac workup, it may be when you're actually presenting with a heart attack. And it's the reason why a first heart attack for a woman is more often fatal than the first heart attack of a man. So we've got to begin to take it seriously. Now, since you asked me, glad you asked. I've got some more stuff to say. So when we talk about heart disease, let's talk about some of the more commonly thought of symptoms of menopause. So insomnia, like not being able to sleep. You can fall asleep, but then you have frequent awakenings, or you have difficulty falling asleep. So it's called duration of sleep is shortened. And we know outside of menopause, this is just cardiology, that sleep duration has a correlation with heart disease. And in menopause, you have an interruption of your sleep duration.
Oh,
You
wow.
also, because of stiffening arteries, those arteries in our bodies begin to be a little stiffer because we don't have estrogen keeping them pliable. Those stiffening arteries increase our blood pressure. So if you already have high blood pressure, perimenopause and menopause is not making it better. It's going to get even higher.
So whatever you're currently going through at that moment, perimenopause is just multiplying the situation in a
It's
way.
multiplying blood pressure, high blood pressure, sleep challenges. The other thing is you can have an increase, and let me just stick with hypertension. High blood pressure, which is hypertension, is also an independent risk factor for heart disease. So now we've got sleeplessness and hypertension that are both risk factors for heart disease. But let's add high cholesterol. Cholesterol levels also increase during perimenopause. Cholesterol, independently of menopause, in men and everybody, is a risk factor for heart disease. And then let's add one more thing, these hot flushes, these hot flashes. We know that the duration and intensity of hot flushes is also correlated with heart disease. And we also know that Black women tend to have more intensity with their hot flushes. So now we have all these risk factors for heart disease that happen all at the same time during menopause. And yet we still don't recognize when that woman comes in her risk factor for heart disease. That's why I am a proponent of understanding that menopause is a risk factor for heart disease. Independent risk factors of heart disease that we would attribute to any other patient, male or female, at any age, they all occur at the same time. often during
Mhm.
menopause. And that's why our risk literally doubles. If we had any other disease process that doubled during a decade, it would really be a crisis in this country. But menopause goes just, ha ha ha, she's having flushes. Oh, this is so funny. Try to wear a t-shirt. It's not a laughing matter. We've got to begin to understand how it increases our risk of heart disease, because not only do we have all these risk factors together, when we do seek medical attention, our symptoms go unrecognized as well. And here's something else. A survey of physicians noted that primary care physicians, only 22% of primary care physicians admitted that they even had any level of comfort treating a woman with symptoms of heart disease. So only 22% of your primary care physicians feel comfortable treating women with heart disease. But here's the surprising thing. Only 42% of cardiologists, that's literally our job. Only 42% of cardiologists feel comfortable treating a woman with heart disease. And when you step back and think about that, it makes sense, because most cardiologists are men. Take a look at me. Not only am I rare as a female, as a Black female, I'm almost non-existent in the world of cardiology.
Yes.
And
Right.
although you guys see me, most people will go their entire lives and never meet a Black female cardiologist.
Right.
So when you look at those statistics, it makes sense. And then one
It really
more
does.
thing, just to add to that, while we're going down this road, data shows that women who are seen by female physicians fare better, they have better outcomes, they spend more time with the physician tends to follow more evidence-based guidelines, and even men who see women physicians also have those benefits as well.
What, men seeing women physicians?
That's right.
Because the women physicians are you're on it.
We're on it.
Getting the job
Follow
done,
the
making sure.
guidelines. We tend to
Mm,
take more time. We're attuned to symptoms. So it's interesting. It's not just women seeing women physicians, it's males seeing women physicians as well. Tend to have better outcomes.
and all those red flags, you would think that any physician would, I guess, just step in and say, okay, we've got to take the next step. And as you were saying, the test for your heart, making sure that gets done. But those symptoms are they're atypical. So it's just not, there's nothing to move forward on. They'll just go off of something else, something
Mhm.
completely different.
Right,
That's, to me, that's just, that's more than scary, that's more anxiety ridden, and I try not to overthink things like that, but
right.
at the same time, I it's our health. We are coming into the doctor when we have that moment, that, whatever time we have, and
Mhm.
we're asking questions and we're concerned, and then those concerns can be written off.
They
Um,
can be written off. Not only can they be written off, they're even written off by us. When I say us, I mean women,
yeah,
right?
yeah.
Because we're not taught as a society to recognize the symptoms that are more likely to occur in women. We're taught to recognize the symptoms that occur in men. And our symptoms can be confused with other things. Generally, chest pain is not really confused with a lot of stuff, but
Mhm.
fatigue can be,
Yeah,
back
that's
pain
true.
can be. Who doesn't have back pain as they get older and they've got kids running around? I mean, so it's all you pop a Motrin and you keep going.
I
So, we tend to do that, and we have to think about that. And there's one other risk factor for heart disease, before we get off of this, if we're moving to something else that I want to talk about that happens during perimenopause and menopause, and that is weight gain. And that
mhm.
weight gain tends to be around the midsection, that spare tire, that belly. That's called visceral fat.
Oh my
Visceral
goodness.
fat in itself is a risk factor for heart disease, because it increases inflammation in our bodies, and inflammation
Mm,
is is inflammation drives the development of heart disease. Heart disease is recognized as an inflammatory process. So all that visceral fat that you develop around your midsection is
Mhm.
not negligible. It's active. And it is causing inflammation, chronic inflammation in your body. And that chronic inflammation can also increase your risk of heart disease. That's number one, in addition to all the other risk factors. And then just the fact that you're gaining weight and developing obesity also increases your risk of heart disease, increases your risk of developing diabetes. And you see how it goes on and on. It's like a snowball effect. And yet we're just invisible. We just kind of go through. Nobody really even notices what's happening, including ourselves. And the reason for that is that doctors have not been trained on menopause therapy because of the Women's Health Initiative that was a large study of women 25 or 30 years ago in the 90s. It
Mhm.
started 30 years ago. The data came out 25 years ago. And basically, they were looking at women and they wanted to know if menopause impacted heart disease negatively. So they did this trial, they enrolled thousands of women, and drew all kinds of erroneous conclusions because of a number of reasons. And maybe I won't go into it, but I'll just give you some of the highlights. One, they're studying women in menopause, and yet they had women in their 60s and 70s in the trial, well beyond menopause. And so then
Mm.
they draw conclusions on one group based on data from a different group. They
Mm.
also determined that hormone replacement therapy, HRT, which is now known as menopausal hormone therapy, MHT. Again, I don't know who's making these decisions. They're just making it so confusing, but HRT and MHT are the same thing. This is
Okay.
hormone therapy. So we're using those terms interchangeably as we're going through this transition. That
And
women,
thank you for clarifying that, because I did see that in my research and I was a little confused. So thank you
same
for
thing.
stating that. Yeah.
Same thing. I don't know why they don't give an explanation.
Mm.
So women who were on hormone replacement therapy in the trial, this is how the trial was shut down, showed that they have an increased risk of breast cancer. But that wasn't really true. What they compared it to placebo, meaning women who were not on the hormone replacement therapy. But it turns out the group of women who were not on the hormone replacement therapy had many of them had been taking estrogen immediately prior to enrolling in the trial and being randomized to the placebo group. So they already had the effects of estrogen. So then when they compare, they say, oh, look, the placebo group is doing better. So it was just all of this. The same for they didn't look at the subpopulation of Black women, and no surprise there. But when we went
Mhm.
back to look at the subpopulation of Black women, many of whom had had hysterectomies, and that's a completely another ball of can of worms as to
Wow.
why Black women have more surgeries, more operations, more hysterectomies, more C-sections, higher maternal mortality. So that's another topic. Invite me back on another day. But let just suffice it to say that Black women were here, many of whom had had hysterectomies. And in that subgroup that they did not really look at, not important, that subgroup of women who were all taking estrogen actually had a decreased risk of breast cancer. But that was never published because they didn't look at the subgroup. And this is a subgroup that was very interesting because many of them did not have had had hysterectomies.
So they
So
completely wrote it. They just
just
passed that.
one erroneous conclusion after another. Now, this team of the Women's Health Initiative has started to post retractions. But in some
Okay.
ways, they still are standing by some of what they're saying, and we are continuing to challenge their data. And I think eventually the entire study will be debunked. So I'm
Okay.
going over some of the highlights of that, but because of that, because it erroneously showed an increased risk of breast cancer, supposedly, right? They were looking at the wrong group, the wrong indication. They did, whatever. It shut down training in menopause and menopausal hormone therapy or hormone replacement therapy just overnight. in all
Oh my
training
goodness.
programs, all medical schools, all residencies, all fellowships. People like me never trained on it. It was absolutely a no-no, no need to learn about it. We're never going to do it. It was, and again, it relegates women to being invisible. We did not talk about
Mm,
it. For what? Because we're protecting women. We weren't really protecting women by not talking about it anymore, because that leads me to the next topic that I talk about all the time. We then
mhm,
didn't do further clinical trials to get more answers. Because why? Because we don't really do clinical trials, and we don't include women in clinical trials, and we don't for a number of reasons, mostly because they're led by men, the drug
mm,
companies are led by men, clinical trials enroll men. And so there really was no further research looking at it, even governmental research. And you're seeing a change now with the Biden administration really trying to put money towards research specifically for women, but women aren't
mhm.
included in trials, and trials aren't conducted looking at issues that are specific to women. So what happens? 25 or 30 years go by, and nobody's looking at it. And women's heart disease risk is only increasing. Heart disease is the #1 killer of women all the way through COVID. That was what was
Mm,
killing us the most. So we're starting to dial that back now and have these conversations to say, wait a second, did it really increase the risk of breast cancer? Or did
mm.
you guys not really understand the groups that you were looking at, and you were comparing it to a placebo group that actually was already on hormone therapy as well? So that's kind of where we are.
Mm. I The clinical trials are so important.
They are.
I didn't realize how I've heard of clinical trials. I just didn't realize how significant they were. So,
Yeah.
especially when it comes to women.
And that's my
Uh,
background. So I'm a cardiologist, but I
mhm,
also have an extensive background in research. And when I say extensive background in research, I mean in the pharmaceutical industry, working at Solvay Pharmaceuticals, AbbVie. I worked there for years in hard R&D, medical affairs, developing protocols. So I understand the research process, the process of recruiting study sites and recruiting patients. And then I led a huge study site at Piedmont Hospital. The cardiovascular research program was under me for years. So,
wow,
absolutely, I
amazing.
understand how to read research, how to interpret research, how to create research, how to develop research, what clinical trials are. And that's why I've gotten involved in trying to lend a voice from a cardiac perspective, but also I have a unique perspective in that I also have this research background, this very extensive research background that combines with cardiology to really take a look at this.
You are amazing. I'm just over here going like just all of this information. You can't read this. You can't. eh, All the research I was doing, you can't just hearing it from you.
Mhm.
I'm glad that we're able to take the time to discuss this because it's a problem, a big problem, and especially when you were talking about the doctors. And I a long time ago I had a male doctor, and I actually and a question. I'm like, why did I have a male doctor? Nothing against the males, but I was like, he's not going to be able to help me with what I need help with. And I switched over to a female doctor, and I noticed a humongous difference.
Right.
More time on the blood work, more time speaking with me, more time breaking things down. So, just you saying everything you're saying with research and clinical trials and the female aspect of it, I hear you. It's amazing.
And don't be
Uh,
afraid to change doctors. And it doesn't mean that your doctor is bad. I just told you what happened to doctors. We didn't get
mhm,
trained on it. We
mhm,
literally don't know it. It's not that your doctor is trying to do you a disservice. They're
mhm,
literally, you're not trained on it. There is nobody doing it
mhm.
that people know. And so there are people now who have menopause certifications. You may want to look to see if your doctor has a menopause certification, or see which doctors in your area have menopause certifications, and
Okay.
begin to look at those doctors. It doesn't mean that a doctor who doesn't have one isn't knowledgeable, but because we're still kind of on the front edge of this, that one with a menopause certification has taken the time to acquire that knowledge. Again, it doesn't mean that your doctor doesn't have the knowledge, but if you need to change doctors, change doctors. It doesn't mean that your doctor is a bad person or that you hate your doctor. You don't need to walk away in in a tiff, in a
Oh, of
huff,
course, no.
because, you know, it's just kind of like, hey, it's time for us to part ways. You've brought me this far. It's
Mhm.
been great, but now my journey's going in a different direction and I need something else now. And,
Respectfully. Yeah.
that's it. Respectfully, I need something different. Everything you've done for me up to my journey at this point was great, but now I need something else. And I need to find that and find a doctor, who can hear you and understand you. I call it the there effect. You go in to see your doctor and
Mm.
you tell them about all of your symptoms, and they're just kind of pat you on the back. There. Here's an antidepressant. Why don't you take a vacation? You seem stressed.
Mm.
And then, because you're in perimenopause and you're a little edgy, you take their head off, right? And they're like, yeah, give her an antidepressant. When
Right.
actually you just exhibited symptoms of perimenopause, but they don't understand how to pick that up. Like you just exhibited a classic interaction. So instead, they dole out the antidepressants, and I've come full circle on this. I think if you've got all these symptoms of perimenopause and you're not feeling well, and you're seeing doctor after doctor, and you're not getting help, we probably do need an antidepressant. We probably are depressed at that point. So maybe,
It's about
you
time.
know, but the fact of the matter is, before you take an antidepressant, see a menopause specialist and see if you can begin to feel better. We don't have to suffer. And let me talk about that word
Mm.
suffer.
Mm.
We say the word suffer a lot. Women, especially for women, that we just have to suffer. We suffer with it, we suffer because of it, we suffer through it, we say, that's just part of being a woman. And this is the normalization. And even physicians, that's why I say the word atypical, we need to remove it from our vocabulary, because it can unconsciously drive some of your decision making. And the same as using the word suffering and always associating that with a description of something that a woman is going through can drive your decision making, because, oh, this is the woman, she's got to suffer through it. She has let's take that out and not and stop normalizing that, and begin to find out really what our options are, because this is serious business. And there are drug companies who now have come out with medications called VMS, vasomotor symptom medications, that control the symptoms of perimenopause, and you feel a lot better. These are vasomotor symptoms, and you control them. You stop having the hot flushes and palpitations. But here's what I'm going to say about these medications. They don't decrease your risk of heart disease. So
Oh.
they control your symptoms and you feel better, but ultimately, all your risk factors for heart disease are still there. They do not correct your cholesterol level. They do not correct your hypertension. They don't address the obesity, but they do control the hot flushes and things. And so maybe to that degree, that hot flushes have some degree of correlation with heart disease. Perhaps. I haven't seen any outcome data on that. But just remember, that's the real difference between menopausal hormone therapy, MHT, and
Mhm.
VMS, the vasomotor symptom therapy, that are pills that are coming out of drug companies. They both control the symptoms, but the menopausal hormone therapy also restores the estrogen to decrease your risk of heart disease. So we
That
want to
was
make sure
what
that
I
we
was gonna
know the
ask
difference.
about.
And it doesn't mean that one is better than the other. You have to pick what's better for you, whatever your clinical symptoms are, whatever your background is. Um, and it just depends. There aren't a lot of contraindications to estrogen therapy. I won't go through all of them, but I will just say one of them is a personal history, not a family history, but you
Mhm.
personally have had breast cancer. And so if you've got a contraindication, sometimes blood clots, this is all very relative. That's generally more with oral estrogen than patches or whatever, but this is just high level. You have this conversation with your doctor. You don't have to say, Dr. Morgan said, this is what I'm doing. High level, right? Because I don't have time to get into the details, but I'm just giving you high level information. Um, then, it may be that vasomotor symptom therapy is right for you. So there are options, and this is the whole point, because medicine is moving towards shared decision making. And
Mm,
that means that a woman has to be her thoughts and her desires must be incorporated into the decision-making process of the physician. And together, you guys decide what is the best course for you. You decide what you want
mhm.
independently of what the physician advises, the physician guides, but ultimately is shared decision making. So I want to be certain that you all know that. The other little tidbit that I will add, because I know that we're running out of time, is people often ask, my friend takes estrogen and I got estrogen and progesterone. So why did they cheat me? Why did I only get estrogen? So here's, again, high level. Generally, if you've had a hysterectomy, you don't have a need for the progesterone. The progesterone protects the lining of the uterus. If you haven't had a hysterectomy, if you remember what I said with the Women's Health Initiative, a lot of the Black women had already had hysterectomies. You really only need estrogen. If you still have your uterus, if your uterus is intact, generally you'll have estrogen plus progesterone to protect the lining of the uterus. Again, that's high level, and have those discussions with your physician.
Absolutely. Thank you so much. Thank you so much,
So I
Dr.
hope this
Morgan.
was helpful.
Very
Um,
helpful.
and
Very.
so I know someone asked, if you don't want to take hormone replacement therapy or menopausal hormone therapy, or you're not a candidate, or et cetera, what should you do? The main things that you should do are control your risk factors, right?
Mhm,
So if you've
mhm.
got blood pressure, you treat that blood pressure and you treat it to goal. Goal is 120 over 80 or less. It's not 128, 132 is good enough. No, you keep taking the medication and increasing that dose until you get to 120. You treat it to goal. The same for your cholesterol. You treat your cholesterol levels to goal. All of that. Now, something also to say about estrogen therapy. I'll just throw this out at the last minute. I'm just throwing out stuff. I'm just throwing out a few. You
Keep
know,
going. Keep going. We're
women
loving it.
who are on menopausal hormone therapy,
Mhm.
in general, as they get older, weigh less than women who are not taking it. So you gain fewer pounds because you've got this estrogen level, decreased visceral fat. So that's something else to think about as well.
Mm. I remember what you were saying about that. Yeah, that visceral fat. And that's
Visceral fat.
because of the
And that
estrogen
visceral
levels
fat is not
decreasing.
nothing. It's active. That's
Mhm.
that's inflammatory fat. Yeah. And it's
That
hard.
word,
It's hard to get rid of. It's hard to get rid of it. It
it
just
is.
sticks around. Right.
That word inflammation
Mm-hmm.
is a horrible word because every time I hear about, like, of course, heart disease and other disease, and the key word I hear is inflammation. It's the cause
Yeah.
of so many health problems. So, you saying getting and treating those things to goal to make sure
Right.
that you're healthy and safe, that makes perfect sense. It
Right.
makes perfect sense.
Yeah, absolutely. So I hope you guys all got something out of it today. If you want to follow me, feel free to follow me. I talk about all kinds of things. I talk a lot about cardiology. I talk a lot about menopause, but I talk about other health things too, including, HPV vaccine, just anything. But it's on Wednesdays. It's only 60 seconds. You'll know it because you'll see me sitting on the stairs, and it's about to be 60 seconds of something very understandable. I break down the science and make it very easy to understand. And it's only 60 seconds. 1 minute, you're in and out. Boom, you're done. You've learned just one little thing. You don't have to agree with it. Just think about it.
Thank you so much for speaking with us,
Welcome.
Dr. Morgan. I have followed you, so I will be watching. This was an amazing conversation, and I
Good.
really hope listeners learned as much as I did, especially the educating ourselves part making
Right.
sure that we talk about it and we don't, think it's embarrassing or attach a stigma to it. We need to know, because the more that we know, the better we can prepare ourselves and be
Right,
healthy.
the more armed we are, as again, it doesn't mean you have to take hormone therapy. No,
Mm,
you make the decision for yourself, but first have good information and then
mm,
have a shared decision with your physician. We can never make good informations if we only have half the data and half the information.
That's very true. Being very open and honest with your physician and
Right.
talking about it.
And
Yeah,
changing doctors if you have to. In a, without
without the arguing.
consequences. Just
No, no.
I gotta go, but I love you, but you're not right for me anymore, but maybe we can do lunch sometime.
Right. Goodbye.
Right.
Thank you so much. And
You're
I
welcome.
definitely, enjoyed this time. And
Yeah.
I am Kristen, Queen Ayoke. You can follow me too if you'd like. And again, I am loving that we got to talk about this. And I really hope that our viewers and our listeners got a chance
Thank
to
you for
take it all in.
inviting me. It was a pleasure. Everybody have a good night.
Take care, everyone. Have a good night.
Bye.